Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com.
Aloha, Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and medical director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
Hey, hello there. Welcome aboard and glad to have you with us and all that good stuff. We're going to refer you to the website often. It's veinclinicsofhawaii.com. And we're going to give you phone numbers and give you information. And sort of today, I was really looking forward to this because almost all of us, let's say that you find out what your IQ is. You say, well, what's your IQ? What's my IQ? Is mine better than yours? Well, one of the things that I always wondered about is how doctors treated a new patient, especially specialists like Dr. Juliff, like a veins doctor. How do you treat other patients? How do you treat new patients? Well, you got to find out where they've been. And there's been, I guess, and we've never talked about this before, but there's this thing, and it really is classifying where are you on the chart. I know where I am in need of some severe help. You may not be that way yet, but you're sure going to find out today. And that's because, and I guess this is an international way for professionals in the venous surgeon field to communicate with each other, particularly when there's great distances involved. But the benefit is it's good right around the corner just as much. That's kind of a long, convoluted introduction there, Doc. But today's show is going to be maybe helping people understand what the disease is and what its progress is. But more important, where are they in the mix? Are they new? Are they medium? Are they end stage? Where are they?
Right. Yeah. Going through this, it's going to be a nice, also just general review of venous disease. Mm-hmm. But when a patient comes in, we evaluate them. Of course, go through the usual stuff. Do a extensive history, physical exam, and do an ultrasound. And if we find that they have venous insufficiency, then we start to classify that patient. Mm-hmm. And there's a variety of different ways to do that. Some are a little more accepted than others, and we're going to talk about the couple of systems that I think are probably the most utilized throughout the country, mm-hmm. and around the world for that matter. But it's an excellent way to find out or at least indicate where any particular patient is on the spectrum. One thing I thought was kind of interesting when I saw this was, let's say for some reason you move to another country and you need a new dentist. Because I was talking to this about a dentist friend. It's pretty simple. You just send the X-rays. Yeah. The guy looks there. Well, this is a root canal. This is right. It seems like there's a little bit more involved in the venous survey than there is in just an X-ray. Yeah, it probably is. Yeah, mm-hmm. But it also impacts how we treat people. How urgently we feel like we have to initiate treatment. Mm-hmm. All that sort of stuff. But the classification systems that we've come up with. It's been nice because other medical fields don't necessarily have that.
Yeah, I was going to ask you about that.
However, this, particularly the first one that we're going to talk about, it was sort of based on patterned after, I will say, mm-hmm. patterned after what we call the TNM system. Of malignancy, if when somebody has a cancer of one type or another, we like to classify that too, mm-hmm. because that really impacts how they may get treated, et cetera. So,
yeah, good point. I mean, we see a lot in the press these days. By the time he was diagnosed, this is cancer. He was stage 4.
Right.
Stage 4 means you're almost done. You're at the end of it.
It's not good.
Yeah. So if you can get somebody on their way to stage 4, stage 1 or 2, you're better off.
Absolutely.
Yeah. Okay, good.
Oh yeah, and
Yeah.
it gives you an indication of their mortality too.
Yeah,
their survival. So that was used. That has been used for a long time in oncology and evaluating patients with malignancy. But where does the patient stand at the time of presentation? These are some of the questions that can be answered utilizing these systems. To a certain extent, it will imply the treatment that they're going to get. To a certain extent, it's going to imply the urgency that we may feel and how aggressive we might need to be in getting that person into the treatment path.
Yeah, that's another thing that we often mention here on the show, gang, and that's treatment path and treatment, the protocol for treatment. So the severity of the disease either moves up the date or moves back the date when some procedure has to be done or not done.
Yeah.
Because, and I guess it's pretty much true that this is a helpful thing that's been also aided, I would imagine, by technology. When you can get from a guy's previous doctor in another city or another state a transfer of the information that you need to continue on with them.
Because venous disease, it's luckily it's not like having a malignancy. Unfortunately, many of those patients come to an ultimate result. But venous disease goes on for so long. I mean, it's a genetic
Decades,
problem for the most part, and goes on for the entire. So it's really nice to be able to say, gee, 5 years ago this patient was at this point, and now they're there, or maybe they were in another state or another country 5 years ago, and we can easily figure out kind of where the progression over that period of time. So it makes it easier to compare similar patients, just within our own practice. We can kind of identify patients that are sort of similar. It gives physicians the ability to communicate about patients, so everybody's kind of talking the same lingo, and it helps patients to know how beneficial their treatment is for, again, any one patient. So, as we find out where on the spectrum a patient is, day one, and then we go through their evaluation and treatment, and hopefully, day 97, they're in a better place.
And there's another thing, gang, and I actually in previous shows sort of made fun of this, but I mean it as a compliment today, because one of the first things I noticed with my first visit to Dr. Juliff's office, veinclinicsofhawaii.com, little plug, veinclinicsofhawaii.com. The first thing I was handed was an iPad, and it was like, a little like a thing, and here it is, and it was so thorough in the questions that it asked. Even though it seemed a little bit tedious, I guess there's method in your madness. This goes a long way to preparing eventually for the first confrontation, doctor to patient. And many of the questions that we're asking, in our iPad ordeal, will help us figure out where on the spectrum of venous that's what
disease.
I'm thinking.
I mean, that's where we start to figure all that out. So, classification. And then the other thing about classifying patients is that it helps when, from a scientific standpoint, when we're talking about large groups of patients and how we're treating them, what is the standard way to do it. This classification method helps us follow those patients so we can state, scientific fact about whether one thing is working and the other thing isn't. And,
gang, there's method in the madness here, too, because as much as I think it's possible, it's hard to paint a picture here on the radio. Even if you get really close to your speaker, you're still not going to see what we're talking about. But when you go to veinclinicsofhawaii.com, you can see, and that's why some of the questioning will be about these things, these venous ulcers, which are a really bad thing you get later on in the disease. But you can see I got a little hole here, and here's a picture at your office. It's like a gaping hole, and this is what you can say, okay, this will turn into this if you don't do this.
Right.
That's kind of that. But actually, it's good to know as a patient, because you say, well, whatever that is, I don't want that. So whatever it takes to do this, do this.
Yeah. We've got some fairly graphic kind of things that people can look at when they're in the office, and some people get turned off, but it is.
I'm fascinated by it, by the way.
Well, and it's motivating for the patient to say, "Gee, maybe I do need to have something done here." So anyway, the first classification system that we're going to talk about is called the CEAP system.
CEAP.
Yeah, and that's those are the letters involved. This was something that was developed in 1994. It was revised about 10 years later, and it gives us a very good picture of where that patient is, again, on the spectrum at one single point in time. And each of those letters stands for a different component to the overall classification. The first one, C, means clinical classification. And by that we mean, what clinically, what do we see here with the patient? And
but by the way, let me make sure that people get this. Sometimes just by seeing a leg that you haven't seen before, you can say, this is a result of all this. You don't need to see the all this because it's here already. Yeah. Right? Yeah, that's what I'm thinking.
Yeah, that happens.
Yeah.
That happens all the time. Where it's funny with venous disease, the appearance of people's legs are very typical, depending on, what they have and at what stage they're at. So it's pretty easy to pick out one from another. But so the C part of this classification is 1 through 6. And we've talked a little bit about this in the past, but just to kind of give a quick overview, C1 through 3 are a little less threatening stages of the venous disease, and that has to do with C1 indicates spider veins only, C2 varicose veins, C3 swelling. So again, just kind of an easy way to classify at what stage that patient is at. And as you go up through these numbers, you do actually progress in severity of the disease. So I mean that's kind of the way why we do it. But so 1 through 3 is spider vein, varicose veins, and swelling. Stage or C4 means that there are skin changes.
Right.
So, when we say skin changes, we mean, the skin starts to thicken, it starts to darken, it just becomes skin that looks abnormal. And there's a variety of different ways that it can look.
Yeah, and the one that I came to grips with was on my leg. It's the lower leg. It's this little gator thing. It's below the calf, and it's above the ankle. And so I guess that's the tell-all of most of us with venous disease. That's where you can see it.
Yeah, that's an important area.
Although it certainly happens in other places. For some reason, I guess it's maybe the closeness of the veins to the skin or whatever, that when you get a problem with one, you can almost see it from outside.
Sure. It's kind of based on the anatomy, or those changes happen because of the basic anatomy of the venous system. So that's 4, and then 5 and 6 has to do with ulcers. And C5 means that patient has had an ulcer in the past, but it's healed. And then C6 means that patient has an active ulcer at the time that they're presenting to you. If somebody presents with an ulcer, we feel a little more urgency in getting their evaluation.
And I got to tell you something. The reason I get to sit here is because I'm also a patient. And I went in last week for an upgrade, a test, and a procedure. And when I go in there, darned if there isn't this little hole in my leg that wasn't there but a couple of days ago. And I found out that, if you're predisposed to having a leg ulcer because you've had one, that you might get another one. I said, not me. Now that I know what they are, I'm not getting another one. Well, I have the makings of one. Mm-hmm. Now, good news is that we've detected that very early.
Right.
So it's going to get treated and not probably need too much. But this is the very same thing that some person might put salves or ointments on or Band-Aids on for days and then weeks and then months and nothing happens because
Yeah.
it's not what you think it was.
Yeah, so we would classify that your left leg currently as a C6 because you've got an active ulcer, as opposed to your right leg, which had the ulcer before. Right?
Yeah, it did. Yeah.
So you would basically be a C5 classification because
On
you
the
had
other
it healed
leg.
a long time ago, but it healed, and luckily that has stayed healed. So that's a good thing.
Yeah, so we'll be obviously quite aggressive in hitting this in the very beginning, and I think that what's happening, and I think you explained this once in other programs, there are more and more places that are wound centers or wound treatment places,
right?
And highly recommended because if you misdiagnose a wound, you can delay its healing by a long time, right?
Oh yeah. Wound care clinics have really kind of been a tremendous benefit because they really, they focus on an ulcer and they really do all the things they need to do to get it healed in one way or another, whatever it takes.
Okay, what about in my case? Here I had this horrific problem with my right leg a long time ago. One would thought, well, if I'm going to get another one, it's going to be in the same place or the same leg, different leg. So my legs aren't talking to each other unless they got something going on that I don't know about.
Yeah.
So does that mean that it's just your system is your system? It may not know exactly where to crop up, but it has the probability of doing it?
Yeah. It kind of goes back to your mother. Since it's genetic.
Poor lady. I've been yelling at her for years. She's long gone. Yeah.
So, you've got the same problem in both of your legs.
Yeah.
And it's just, the things had progressed on that left leg and, you bumped yourself and boom, you got an ulcer that is probably not going to heal until we get things, all settled down. So the next category is E. Yeah. And E indicates or means the etiologic classification. So what is the etiology? What is the underlying problem here? And the three basic ones are congenital, what's called primary, and then something called secondary. So in the congenital category, for instance, there are people who congenitally lack valves in their veins.
Yeah, this is at birth or whatever.
They were born without valves.
Good.
Yeah. So that would be one example of a congenital etiology.
I got a question on that. I think you answered this once before, but it was about a patient that had real bad problems with one leg, and because there were no valves, and the other leg was kind of normal.
Right.
That seemed abnormal to me.
Yeah.
I mean, but obviously, if your leg never has any valves, isn't that leg susceptible to some serious problems?
Oh,
at some point?
Definitely.
Yeah.
By definition, you will have
no
reflux.
valves, no problem, no circulation.
Yeah. I mean, no valves, blood in veins is not going in the right direction.
Yeah, gee whiz.
So it could be a bad problem because they have that from the very beginning of their life. So that's congenital. Then the primary etiology, something the category that we call primary, are those people who have valve failure. Those are people who have normal valves, normal anatomy. They're born with normal things, but over the course of their lifetime, for whatever reason, those valves fail and they start to develop reflux in those veins.
And these are the ones that generally, like in my case right now, getting jumped on to get in there and get rid of these bad veins and eliminate the areas where those bad valves are and redirect that circulation so it goes to a better path.
Right. Yeah, exactly. And then the secondary the secondary etiology category refers to people who might have had a blood clot in the past, which is also, by definition, often going to affect the long-term function of that vein. Injury, post-surgical abnormalities that may arise. So the secondary, obviously, is venous disease secondary to a specific event or condition. So then the next category is the A, and that stands for anatomy or anatomic classification. And basically that is just indicating what part of the venous system is affected. We've got several different systems of veins in our legs. We call those superficial and deep.
Though to be like spider vein things?
Well,
Superficial?
no, actually, no. They're a little deeper than
Okay.
that. You know, when we say superficial, we don't mean the things that you see on the surface of your skin. Superficial are more superficial than the deep system.
Okay.
It's still a very important, part of your venous system overall. But the superficial system carries a little less overall blood flow as opposed to the deep veins.
Okay.
The deep veins are deeper in the leg. Typically, they're a fair bit larger than the superficial veins. They carry the majority of the amount of blood coming back up from your legs. But even though they don't carry as much, the superficial system luckily is more frequently the underlying problem that we're having to deal with. And I say luckily because we can treat the superficial veins. It's quite a bit harder to treat the deep veins.
Yeah, we
when
talked
they
about
reflux.
that a lot, by the way. The deep veins are that exactly because they're inside deep. And from what I understand, they're larger. Most of the deep veins are pretty big veins. They're doing the heavy lifting.
Right.
But, however, there's no reason to worry about your deep veins being a big problem if you have spider veins because the conditions are not necessarily connected with each other.
Not necessarily.
Yeah.
No.
Good. That's good. Okay.
Then the other part of the venous system in our legs are veins that are referred to as perforator veins.
The P part.
Yeah, and those are the shortish kind of veins that connect the two systems. So these are short veins that connect the deep veins or the deep venous.
Do they go
system
sideways
with the
most of the time?
They do.
Yeah.
They go probably what you might think of as being sort of perpendicular to the surface of the skin because the other systems are going more parallel.
Sure, gotcha.
And they're not, it's not like they're straight connections. I mean, there's a fair amount of.
Can they be very long or are they pretty short?
Most of the time they're relatively short, but they can be a little they can be long, not the length of your leg type thing, but typically they're a fair bit shorter than the other ones. So those are the three anatomic classifications, and that gets put into, again, when we're kind of notating or writing down, where does any one patient stand on this, then, there's a specific way to indicate under the A category, what are we dealing with? Are we dealing with superficial or deep or perforator? And any of those systems can falter in their function and show reflux. Then the last category is within the SEEP classification.
Is the P.
The P. And that refers to the pathology. What is it that's going wrong here? And the pathology basically is there reflux? Do we have primary kind of valve failure and the blood's going in the wrong direction, or is it obstructive? Did that patient have a DVT 20 years ago, and now they're seeing the ramifications of that over a long period of time, or is it both? Some people might have both. Some people might have reflux. But also on top of that, an obstructive process that is interfering with their function. So, and then part of this also, we're not going to go into detail here, but when we again notate it, we notate what the pathology is, and then there's a numbering system that will actually indicate what specific vein you're dealing with, or what specific vein you're referring to.
And certainly, I'm guessing that the more standard these terms become nationally and internationally, I don't want to say easier it is, but the more likely it is that the next doctor is going to get a clearer picture of the patient quicker.
Right. Exactly.
Which really aids in the ongoing treatment plan.
Sure.
What about finding out, where the person is in treatment so far? Is that also in most people's records?
I think, we can often, you referred to the dentist before.
Yeah.
And I would assume that he or she said, we can just take an x-ray and kind of see what they've had done in the past. And to a certain extent, we can do the same. I mean, usually when we do an ultrasound, if they've had treatment in the past, we can kind of sort out exactly what's been done.
I'm glad you say that because I want you to understand that, I'm not just the I'm, highly paid host of the program, but I'm also a patient, and the two have one to do with each other. And it's very interesting to me to learn that we did this and we're doing this again, and sort of here's where you are and here's what you can expect. Because I think isn't that the most important thing is that people can sort of semi-recognize. Okay, well I think I'm becoming the next rung on this ladder, even though it's not scheduled. I got to go see the doc. Mm-hmm. So that means that I'm imagining that a certain percentage of your patients will just show up on their own, call the office and say, "Hey, it's been a while. I need to come by."
Yeah. Sure, they do, and they may be doing that just out of kind of a gut feeling that they're getting worse. But for primary care physicians in general, having an idea about this is good because, for instance, just looking at the C part of the classification, if Mrs. Smith has had varicose veins for a long time and really hasn't been interested in doing anything about that. And then 10 years later, she starts to have chronic swelling, which is the next step up, or even starts to have skin changes, which is even the next step up. Then, probably you'd want to be a little more directive in getting that patient to treatment because it's getting worse.
One thing that I know that Vein Clinics offers as a service, because I asked about it, because asking about, okay, now when should I have this looked at again, whether it be annually, semi-annually, or whatever. Sometimes at the end of a bunch of procedures, like I'm going through, I'm just at the end of certain things that we've been trying to get at for a few months and finally now have with our schedules and everything, and that is that I automatically will be contacted. I mean, one of the things that the office does, and this is not to get patients, this is just to inform you, by the way, the last time you were here with treatment was 6 months ago. Are you feeling anything? Just checking up on you. How you feeling?
Right.
That's very comforting. For a patient.
Well, I think most people do like that. I think our standard is to, recommend that once everything's all kind of completed, we do at least yearly. What we call surveillance ultrasounds, but if somebody has going back to the classification, if somebody has a high classification disease process going on, we treat them. We treat as much as we can with respect to the things that are going wrong or going bad at any one point in time. But, that those people who are a little more advanced, we might want to see them a little more frequently.
Sure, absolutely.
To make sure that we stay on top of things. So, is the SEEP classification enough information? Now, that gives us a lot of information. There's no question about that. However, it doesn't give us as good of a concept of how things are changing over time, and there are, other systems that are a little better at that. So we're going to talk about a couple of those. The systems have been developed by clinicians, and they, want to be able to classify the patient by a little more of a symptomatic standpoint, and get a little better idea where they are, more clinically and symptom-wise, and get an idea about the severity of what they have going on via those kind of parameters.
Yeah, there's another thing that I learned, this was a while ago, that there are many symptoms in vein disease. There's many symptoms and diseases that are similar to more than one problem. And so when you've had, by process of elimination, let's say, numbness and pain that brought you to your vein doctor, when you got treated and it went away, that was a hit. So the next time it's coming back, the patient can almost say, is this back? Mm-hmm. You know what I mean? In other words, here's an early warning sign that I can get back in there and be a lot less of a problem this time than I was last time.
Right. Yeah.
That's the hope anyway.
Yeah, yeah.
Right?
And people do that. I mean, people do identify after they know what's going on, after they've been in and we've treated them, and they have identified, before I had these symptoms, I was treated and now the symptoms are gone, but then several years later they can identify that, that pain or, like you say, the numbness or tingling or whatever that I had before seems to be coming back. There must be a reason for it.
Yeah, and that's, the good and the bad news about the disease. The bad news is that if you have the disease, you're likely to still have it. But there's not everybody doesn't go from having spider veins when they're a teenager to a bleeding, ulcer when they're later, because sometimes it just stops for some reason. Whatever's conditions there just doesn't get any worse.
Yeah. So these additional classification systems do a little better job at following the patient over time. And why do we want to do that? Well, we want to get an idea of the effectiveness of our therapy, and as I mentioned before, it's nice to be able to compare similar patient groups and how they're kind of moving through the process. So there have been other classification systems, and again, these are more weighted in symptoms. And there's a little more weight to the way that it's calculated with the higher level symptomatology that might be referring to a higher level of the disease process.
So not every patient's going to require the amount of work that's being done to study that, to go on that particular patient, because if they haven't progressed past a certain stage, they're not likely to, at least at that time, need additional treatment or additional testing.
Right. So one of these things is called the Venous Disability Score, and basically that just again assesses symptoms and how impactful are those symptoms to the patient's daily activities. What are the things that they can do? What are the things they can't do? What are the things that they were doing, 2 years ago that they just can't seem to manage anymore because of their symptoms? So that's something that we call the Venous Disability Score. Then there's something called the Venous Segmental Disease Score, and that has to do with more of an anatomic evaluation of what's going on. The anatomic evaluation is detailed, pretty completely in the SEEP process that we mentioned before. So typically that hasn't become a integral part of what we do on a day-to-day basis. But the additional scoring system that has probably been more generally accepted and utilized is something called the Venous Clinical Severity Score, VCSS.
Yeah, and I saw that, and that seems to me to be particularly of advantage to people that are really a pretty serious victim of venous disease. For whatever the reason, they've discovered it, and for whatever the reason, it's being worked on. And I don't know if there should be high expectations, but isn't it sort of mandatory that you get that picture, that you know where they are all the time?
Yeah. Well, you bet. I mean, it helps you so much.
Yeah.
Knowing again, where was that patient when they showed up? What did we do to them? Yeah, and after we've done procedures on a patient, is their score better? Because that's the goal, to make them feel better and be more functional. So the VCSS is something that goes very nicely hand in hand with the SEEP classification that we went through, and gives us a little better idea again of how that patient is moving with time and treatment. It's a little more sensitive to change. For instance, ulcer size. Let's say a patient comes in with an active ulcer. The ulcer size decreasing is not going to be appreciated in the SEEP classification. In the SEEP classification, if you've got an ulcer, you got an ulcer. Yeah. However, in the VCSS system, we'll talk about this in a minute, but it gives you the capability of giving that patient a lesser score if their ulcer is much smaller, or if there are, let's say you had 3 ulcers before and now you only have 1. So it's able to, it's sensitive to that kind of stuff.
Okay, now, every time this comes up, we end up explaining to a lot of people what this is. There's so many misconceptions about the word ulcer, and most of us think about an ulcer is an irritation in your stomach for some other reason. You got this peptic ulcer or whatever it is, and I found out that I don't know why. Maybe they just get tired of using simple words, but it ulcer just means a hole. Mm-hmm. Period. I've had a couple of holes in my leg. Those are called ulcers.
Right.
They can be little tiny things, right, like a pencil eraser.
Yeah.
Or they can be silver dollar size or huge.
Or some especially venous ulcers. Sometimes they can be very large.
I saw one, believe it or not, that wrapped around the entire leg. Mm-hmm. In other words, there was a canal in the skin that was missing.
Right.
And that, to me, I thought, this poor guy must bleed every day, but it didn't.
No.
It's a really awful thing to look at.
Yeah.
And I guess the easiest way is cover it up. Don't look at it. Because it doesn't go away.
Not by itself.
Yeah.
Not by itself. Typically those people need, pretty aggressive treatment for their venous disease and also a very aggressive treatment for the ulcer itself.
Okay, here's a selfish question, because I had this one big one, and now I have another one. It doesn't look like it needs to be anywhere nearly as aggressively treated because it didn't seem like a big problem. But isn't it the same thing?
It is.
Yeah.
It kind of, the fact that you have an ulcer, and again, that's why ulcers are C6. That's the highest level, is because it's an indication that your venous function is not normal. Mm-hmm. Even though this ulcer is much less threatening or much not as visibly.
Yeah, I'm a coward because I don't want to watch it grow.
Yeah.
I don't want to say, well, where's this going to go?
Well, that's good.
Yeah. But what I can tell you, gang, and this is really important. It's important if you're a person that suffers these things, is what really happened to me on this particular episode, I think, was my inattentiveness to the fact that I had symptoms that needed some treatment. So, and that usually has to do with Doc was explaining earlier, and maybe you can re-explain it in layman's terms. Swelling. Swelling is a big symptom.
Right.
And I had this swelling that I was sort of just laying it off. It's not that bad. But it was actually getting worse and bigger and harder. Mm-hmm. Instead of being supple, I found my skin down there was pretty hard.
Right.
And, usually, the old push the thumb in test didn't work because it was like a brick.
Yeah.
So there you go. So here comes an ulcer. And now that I reflecting backward, had I seen this thing in a couple of weeks, if I weren't coming in for treatment, I would have known by then that I think this is another one of those things.
Oh, yeah.
Yeah, because it's not responding.
Because it probably was not going to, kind of progress to healing by itself.
Yeah, but if you have a little tiny hole in your leg right now, don't get in an ambulance. I mean, there's, but you certainly should know that if putting a Band-Aid on it and some of that little silly ointment after a few days hasn't cured it, it's not going to cure.
Yeah. No? Well, and the other important thing that you just mentioned was this, the concept of swelling. Mm-hmm. And, swelling is the C3 level. But it's sort of a bridge. I kind of always think of swelling as the bridge from the not so bad to the bad.
Sure. Yeah.
Because, the chronic swelling and, the longer it's there, it really sets up the whole, the physiology of the skin and et cetera, that was going to ultimately lead to ulceration and certainly at least skin changes. Okay,
and gang, that's why we ask you to go to veinclinicsofhawaii.com and take a look at some of the materials available to you there, because there's another thing that happens, and that is swelling in the legs can be attributable to a number of diseases. We've talked about that a lot. Not all of them are venous diseases.
Right.
I mean, a diabetic leg swells. A person with a very bad sprain or a break swells. Mm-hmm. I mean, swelling, but nailing down what's making the swelling is a relief when you finally find out.
Right. Yeah, because, then you can attack
Who wants to be swollen? Yeah.
So looking at then the Venous Clinical Severity Score, it has different categories too, just like the SEEP system.
Yeah.
And there's 9 or 10 different categories. It depends a little bit on how you look at it, but each category is given a score ranging from 0 to 3, and we're going to go through each category. So 0 basically means that you don't have that symptom, and then 3 would be the highest level of that symptom, and so it goes from 0 through 3, 4 different categories. So you look at each category of the severity system, and then you assign each one a number. then you total that number at the bottom, and that's your VCSS score. And again, I mean, so even without looking at the individual categories that you're compiling to come up with that score, just by looking at that bare number, it gives you an idea about,
now I'm getting
if you're 5, you're sort of at the lower end. However, if you're up around 18, 19, then you're getting to a point where, you've got fairly advanced disease.
Yeah, and the interesting thing about that is at every level, you can explain this in a minute as we're going through these things, there's a different treatment plan with every level of severity that we're talking about here. And that not all of these treatment plans are the ones that you'd be, fainting over thinking about maybe having to have them, because some of these things, even some of the things that I've had, are things that are way, way down the road with regards to advancement of your condition.
Mm-hmm. Yeah. Sure.
Which is good.
Yeah. So again, these categories have been picked in a way that is going to reflect in the best way possible from a clinical sort of standpoint. What is the severity level of the venous disease that any one person has? Mm-hmm. So the first category is pain. And, like we've talked about on a number of different occasions, pain means something a little different to everybody. But I think pain, achiness, heaviness, throbbing, burning, all those sorts of words kind of fall into this category. Again, 0 is no pain. 1 is occasional pain, and it does not interfere at all with daily activities. Mm-hmm. 2 is daily pain that interferes with activities to a certain extent but doesn't prevent activities. And then 3 is daily pain that does prevent, some of the daily activities that patient was either doing before or still wants to do.
Yeah, and that gang is exactly what we work on here. I mean, seriously. The object is to have a better quality of life, not just length of life, but quality of life based on getting identified what your conditions are. I mean, who wants to sit around all day and waiting for somebody else to go get the mail so you can see what's in the mail, then you going and getting it.
Right.
Just a little thing like that can make a difference to people.
Sure. Yeah. And I think in that pattern of 0 through 3 is, as it relates to pain, is very similar in each of these categories. It kind of goes from none of the symptom to this symptom that is really interfering and indicating advanced disease. So the second one is varicose veins. As it relates to venous insufficiency, and some people have none, but they still have venous insufficiency. So they get a 0 here, even though they're going to have an overall score on the VCSS. Number 1 is a few small scattered, varicose veins that also include coronophlebectasia.
Oh boy. That's another one of those $1.50 words that I don't get.
That's a nice.
What is that?
That's a nice word.
Yeah.
And it just. I mean, so many people have this. Yeah. It's those little spiderish kind of veins that start to accumulate around the ankle, and we call that coronophlebectasia. Corona means crown. So it's sort of, I think it originally came from the idea that these veins are sort of the crown of the heel because they're kind of fanning out around the ankle. And a lot of people have that. It's a very classic sign for, venous insufficiency. That's why we always look for it. And it's also something that nobody likes. Everybody hates those little veins around their ankle. I was going to say, we already know about spider veins and that being an elected procedure. If somebody is bothered by those other ones around the ankle, same thing, because it's looked at by the insurance company as being appearance, not medical. Yes. Yeah. Spider veins, no matter where they are, for the most part, are considered purely cosmetic. And
I get it, and I've talked to a lot of your patients, and they get it too. I mean, if it's something that's totally elective, I mean, you can't go to, say, once again, using other professions, like you can't go to an orthodontist, for instance, and say, are my teeth perfect? Because nobody's are. And, so the insurance company might say, well, it's not important to his bite or to his chewing or his looks. We're not going to cover it.
Yeah. Yeah, it's reasonable.
Yeah.
The insurance, in support of insurance companies, they can't cover everything, know. So then the next category is edema, swelling. And that's also, kind of, again, they're all separated between 0 and 3, and 0 is none, and, 1 is just around the ankle, 2 is into the calf, and 3 is higher and possibly even into the thigh.
Yeah, maybe some of you are like me saying, you know what, Doc, I used to have ankles. Where in the heck are my ankles? They're in there somewhere.
Right. Yeah, it's still there. You just can't see it. The next category is skin pigmentation. And again, that's that's we talk about that all the time. Discoloration of the skin is very important in kind of figuring out where in the spectrum of vein disease any single person is at. It indicates that we're getting into those higher levels.
I was going to say something, gang. If you're on the porch listening to our program today, and your spouse or your grandkid says, "Gee, Papa, your ankles are all red." And you say, "Yeah, sunburn. I was out doing the yard." You know what? It's not sunburn. This is very well a little sign saying that you're turning red here for a reason, pal. You got to take a look at this. Skin pigmentation is something that is very, very frequently misdiagnosed or ignored. Or now,
whatever.
When you say it's in the ankle area, I'm guessing that you're talking about. Usually, there's about maybe an inch from the bottom of your leg to your ankle. You know what I mean? Like a space in there. Ankles aren't on the very bottom, a little bit up above it. Yeah. So what's happening is it can be underneath that vein, underneath that ankle, and to above it. So you're not looking at a 7 or 8. You're looking at what, 5, 6 inches?
Yeah, well, for that lowest level, for that number 1 level, it would probably even be less than that.
Okay.
It would be, when we start to see pigmentation, typically it's going to start around the ankle. So we're talking about, 2 inches, a 2-inch area.
A band.
Centered, in the area of the ankle. And that would be that lowest level.
Okay, somebody asked me to ask you this.
Yes.
Inside or outside or both? In other words, I noticed that my discoloration seemed to be on the inside of my ankle. I don't know why, but that's just the way it seemed. Is that atypical?
It's probably a little more common to be on the inside, but it can go all the way around. Yeah. I mean, there's no question about that.
We've explained before, the shin is all of that stuff is very close to the surface. Behind the shin, it's not. It's deeper inside. So you're more likely to see the problems on the inside. I mean, the outside. Of the bottom?
No, I think it probably has more to do with the fact that, the anatomy of the venous system and what part of your leg is feeling or getting the worst of the byproduct basically of vein failure, and it has to do with venous hypertension. As veins fail, there's increased pressure inside those veins, and the inner part of the leg typically is going to see more of that just because of the way the veins are anatomically. But when that skin discoloration happens, again, it doesn't happen in the same way in everybody. It's probably a little more commonly seen on the inside of the leg as opposed to just the outside. But it starts on the inside, go all the way around. Yeah,
I think we're more likely to inspect the inside because it's easier to see.
Well, that's another part of it too. Sure.
Okay.
So there's something called inflammation. And inflammation is just, a redness to the skin. I mean, I think most people can identify that. With the higher levels of venous insufficiency, the more inflammation we may see, when the patient presents to us. Now, the redness sometimes is sort of misdiagnosed as cellulitis. We hear a lot of our patients, come in and say, yeah, gee, my leg got all red, and went to the ER, and they put me on antibiotics, and I rested for a couple of days, and then now it's getting better. And I think often they assume that it was the antibiotics that was getting them better, but usually
it's just backing off on its own.
Yeah, well, it is because they're. But I think probably more than anything, they're going home, they're putting their legs up,
exactly, doing all the right things,
and again getting rid of the swelling that often is the instigator. But but inflammation is something that we see. Along with that are other skin kind of things, dermatitis, something that we call venous eczema. All of those things kind of fall under this category of inflammation, and again we sort of classify the 0 through 3 levels as far as how much of the leg is is involved in that process. Number 1 just down around the ankle, and 2 higher, and 3 the highest within the calf. So then there's also along the lines of inflammation, there's something called induration. And induration is another category that we assign a number. And induration is exactly what you were describing before, with your skin starting to feel thick, and you push it, and it's become harder to kind of put your thumbprint.
Get the old dent going. See, whether you need a water pill or not. A lot of people use it as an indicator, right?
Yeah. And that induration is just a sign of chronic inflammation. And that comes along with the whole, concept of ongoing long-term ongoing venous insufficiency, venous hypertension, and all of the things that come along with that on sort of a biochemical sort of level.
It sounds to me like if you are in that condition, that ignoring it's not a very good idea.
No,
that you really it looks also to me. Correct me if I'm wrong, because I've had this condition. It doesn't really reverse. It gets handleable, but it never is going to go back to having that nice, clear-looking pink skin that you used to have there, right?
Probably not. Probably it's not going to go back to normal. Just like, unfortunately,
that's the new normal.
Unfortunately, pigmentation is another one of those things that does not resolve with time, and a lot of people come into us and they so want us to treat them and to make that pigmentation of the lower leg go away, and unfortunately, we just can't do it. So then the last couple categories are ulcer. Now, ulcer is divided into 3 kind of categories, having to do with the number of ulcers, is 0 to 3. The second subcategory is the duration. If it's only been there less than 3 months, then it's a 1. If it's 3 to 12 months, it's a 2. If it's more than 12 months, it's a 3.
All of those need treatment.
Yeah, all of them do.
Every one of them.
Your duration at this point would be a 1, because since it's only a couple weeks old. And then the other thing has to do with size of the ulcer. Less than 2 centimeters would be a 1, 2 to 6 centimeters, 2 and greater than 6. So you have to.
So that's why you measure them and note them down and make all of that.
Yeah. And then the final category is compression. And the compression, I think, was probably included in this because of the fact that if you, in a patient who is always using their compression stockings, and they're still having symptoms, then that sort of implies that there's a lot more going on, and it needs to be looked at. You bet. Yeah,
and you really need to be those things. We've waited, but I'm wearing a different set now. These are thigh-sized temporarily, and I think the quicker you realize that these are a tool that are going to make you do more things that you want to do, the better, right?
Right. Yeah. Sure.
Okay, so in the end run here, there's now, it seems, hopefully some of our listeners will get this, a tremendous amount of categories and criteria that you get figured out to find out where I am, and more importantly, where I'm going.
Sure.
I mean, you can tell me where I am all day, but I want to get something get fixed.
Yeah. And for the patient, I think it helps to be able to define those things. because it kind of gets them more on board getting treated and getting better again.
Okay, I hope that this has been some sort of a pleasant experience for you. I know that I've learned even about myself today a lot, and it's my hope that you learn the same thing. Now, if you really want to get more information about this or anything else, you want to go to the website. That's veinclinicsofhawaii.com. 4 islands, Big Island, Kauai, Maui, and, of course, here on Oahu. Veinclinicsofhawaii.com. You're going to see a lot of other cool things there. There's some really fun things that you can do, but more importantly, you can see some testimonials and see what we've been talking about instead of listening to it on the radio. We'll be back again next week. Tell your friends. It's the Vein Clinics of Hawaii radio show, but you can find out way more at veinclinicsofhawaii.com. That's veinclinicsofhawaii.com. See you next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.